following episode is brought to you by the American Urological Association. This episode features content from the AUA 2026 meeting in Washington, D.C. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support for this activity has been provided by independent educational grants from AstraZeneca, Immunity Bio, Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, and Urogen Pharma Inc.
All right, well, we're gonna go ahead and kick this off, and some people will probably continue to stream in as we're doing this. So I first want to welcome you. This is a new thing that the AUA is doing, is focus on program, and so there's several focus on programs, and today we get to talk about non-muscle invasive bladder cancer. The AUA is striving to offer outstanding educational courses that improve your learning, so please make sure to fill out your evaluations and general feedback so we can continue to improve that. So first of all, I want to introduce our stellar faculty panel. So first we have Mary Beth Westerman. She's an associate professor of urologic oncology at UNC. She's a urologist. We have Suzanne Merrill, who is at Colorado Urology, and she is a urologic oncologist as well. And then we have Liz Kessler, who is one of my colleagues at the University of Colorado, and she is one of our medical oncologists. They are really phenomenal. I hope you guys have a lot of questions for them and can take in a lot of what they have to say. All right, so the AUA would like to thank the following sponsoring companies for educational grants to fund this program: AstraZeneca, Immunity Bio, Janssen Biotech, administered by Janssen Scientific Affairs, and Urogen Pharma. All right, so now we're going to get into the educational part. So we're going to kind of give you a few questions that are a little bit more general. And I'm just going to have you guys do raise of hands so I kind of know where we're at before we start. And then we're going to go over some agents that are in clinical trials, some newly approved agents, and then some really hopefully applicable case scenarios. So in BCG unresponsive CIS, what's your go-to? So we're just going to do raising hands here so the panel knows kind of what you guys are doing, where you're at, so we can speak to that a little bit. Nadofaragene, hands. Got a few. Pembrolizumab. Okay. N803 plus BCG. Okay. Clinical trials. Okay. All right, guys. Oh, here we have this too. Sorry. I didn't realize this was uploaded into the ARS. So you guys can submit your stuff here. I don't know if this one's going to show when we're done. Hopefully it will. It's amazing how many votes we're getting here, and I got no hand raises. This is an interactive session, guys. Oh, good. Excellent. This is what I was hoping for. All right. So really interesting breakdown here. So clinical trial and pembrolizumab kind of went out there. What's your preferred treatment for TA high-grade papillary-only recurrences? So TAR-200, gemdosi, early cystectomy, repeat BCG. Let's see what we got here. Gemdosi, repeat BCG, yeah. Interesting, TAR-200. Okay. For a healthy patient with recurrent CIS plus TA high grade who refuses cystectomy, what's your next recommended treatment? Pembrolizumab, intravesical therapy, clinical trial, or surveillance? Very interesting. Pembrolizumab, intravesical therapy, and clinical trial. All right, so an overview of what we're going to talk about. Non-muscle invasive bladder cancer has high risks of recurrence and progression. Everything we're going to talk about today, is to prevent the recurrence and progression. BCG remains the standard initial therapy, so we're not going to really focus too much on that. Cystectomy still has its role. Who's getting cystectomy? I think we talked about this a little bit at plenary yesterday, very high-risk patients. So these are patients that have variants, really bad variants, sarcomatoid, plasmacytoid, lymphovascular invasion, and then anyone that has hydronephrosis, always heightened level of suspicion. So why are we going to talk about all these new therapies? Why are they all being tested? Why are they all, getting approved by the FDA? Because BCG failure and shortages have driven innovation in intravesical and systemic therapies, and this is not to be underestimated. Bladder cancer is still an extremely common cancer that we see in the United States, and these are very important new developments that we're going to talk about. So we're going to start with intermediate risk here. I'm going to throw to Mary Beth.
Thank you. Okay, perfect. Thank you. So first one we're going to just talk about, this is the only drug that we're going to talk about in the intermediate risk space. And so really these are those low-grade TA tumors that are multifocal, tumors that are greater than 3 centimeters, or patients who have had multiple recurrences within 1 year. And I think what's important for this product to know is that when they were approved, this is a therapy that is for low-grade intermediate risk only patients. And the trade name for this, or commercial name, is Zosduri. It was approved in June of 2025 based on the Envision trial. It is it's a reverse thermal hydrogel. So essentially it is a chilled liquid, and then it is put into the body, into the bladder, and then disintegrates over a period of about 6 hours. So it has a sustained intravesical release within that time frame. It's given once a week for 6 weeks, and then there is no maintenance that's required with it. And in the trial, they published a complete response rate of 80% or so at 12 months. And again, was in the trial, this was an ablative therapy. So these are people who all had tumors in their bladder at the time of treatment. Let's see. All right, so then moving on to the high-grade ones. So these are FDA-approved therapies for CIS with or without papillary disease. All of these actually were typically studied in the BCG unresponsive space. So these are patients who have had persistent or recurrent high-grade T1 within, or TA disease within 6 months of adequate BCG, CIS persistent or recurrent at 12 months. And these are patients who have gotten adequate BCG, defined as 5 out of 6 induction and 2 of 3 maintenance treatments, or 2 induction treatments. All right, so the first one that was approved, this is they're first to the party after pembrolizumab. This is Adstiladrin, or nadofaragene faradenovec, and this was approved in 2022. And so this is actually a non-replicating recombinant adenovirus that carries the interferon 2 alpha gene. It's given along with essentially a surfactant that increases the penetration into the cells in the bladder. It is essentially given on a quarterly dosing schedule. So that's what makes this one a little bit different than a lot of the other intravesical therapies that are out there. It's once every 3 months. It does require a little bit more of it's a little bit more of a complex handling therapy. It often has to be stored in a -80 and then thawed overnight the night before, and then warmed up to room temperature. So it's not necessarily something that's just sitting on the shelf that's ready to go. Otherwise, in their trials, the complete response rate that was published at 36 months is about 30%. The 5-year data, which was recently published, was a little bit lower in the CIS-only patients. The 5-year complete response is about 5%, and it's a 15% in papillary-only patients. Let's see. All right, so the next one was approved. So this is BCG plus nogapendican or Anktiva. And this therapy is a IL-15 superagonist. Actually, that is given along with BCG. And essentially, by giving both of these together, it enhances the BCG-induced immune response, and it's thought to improve the immune activation. This was approved in April of 2024, and based on the COLT trial, and they have reported about a 40% complete response rate at 24 months. Really, for this, the Anktiva, you have to give it it's really immediate. You mix it with BCG, you give them at the same time. The BCG shortage still remains one of the problems with this, because if you don't have BCG, it's difficult to give this as a therapy for patients. All right.
Yeah, just to add to the Immunity Bio does have a recombinant BCG of their own that if you want to do Anktiva, that they will sometimes give you access to. So just to put that out there.
Yes, and I think since the BCG shortages are improving, and the new facility is supposed to open later this year in North Carolina, so I do think that this, there will be more of a role for that. All right, so the next one, this is still me, right?
Yeah.
Okay.
Still you.
All right, good.
I'm going to do all these.
Okay, great. So this is Inlexo, or TAR-200, also I feel like referred to as the pretzel. And so this is literally a pretzel-shaped silicone drug-releasing system. This is really a novel drug delivery system. It's preloaded with gemcitabine, and it's placed into the bladder through this urethral catheter installation device. Once it's put in, it sort of folds itself into this pretzel and then has a slow release of gemcitabine over 3 weeks. And then at the end of that 3 weeks, patients will come into the office, you take out the pretzel, and then you can replace it with a new one. It is given on this 3-week schedule for 7 cycles total. And then if they have a complete response or remain in complete response, you can go on to a maintenance schedule, which is 1 device every 12 weeks, and that can go all the way out to 96 weeks. This is an off-the-shelf therapy, so essentially it's room temperature storage, and then insertion is fairly easy, and then again, removal is just an office cystoscopy. The other contraindications related to this are just any kind of bladder anatomy that would preclude safe placement. This was approved in 2025 from the Sunrise 1 study, which they had a complete response of 51% at 12 months in that study. And then finally, gemcitabine and docetaxel. So this is not FDA approved, but it is fairly commonly used in academic centers, at least. In all of the retrospective data that has been published, see complete response rates anywhere between 40 and 60% between 1 to 2 years. This is typically given, so this is given sequentially in the office. Basically, patients come in, gemcitabine is given first. This is left in the bladder for about an hour, drained, and then docetaxel is placed. The dwell time with the docetaxel is about 60 to 90 minutes. And so this is given in a once a week for 6-week induction schedule, the same one that we're very used to. The maintenance schedule is a little bit different than BCG, so that is monthly, typically for 2 years. Some of the challenges with this are workflow related, so can be a lot of time for a patient in the clinic office, and unfortunately the reimbursement is also not great for this, but this I think is being used fairly frequently and mostly in academic centers. And then finally, let's just mention the cysto trial. So in I think non-muscle invasive bladder cancer, we have a belief that everybody wants to keep their bladder. Cystectomies are horrible. And so it would also be very difficult to do a randomized trial where people got randomized to keeping their bladders and getting novel, next line therapy, or cystectomy. Letting a computer decide that is difficult. And so this was a trial that was designed to be a pragmatic study looking at patient-reported outcomes as the primary endpoint. And actually there was 560 or so patients that were enrolled, about 400 in bladder-sparing therapy, and then 170 into the cystectomy arm. And the authors hypothesized that quality of life, which was going to be their physical function, measured by physical function, would be better in people who had their bladders at 12 months. And that hypothesis was actually not correct. There was no difference in physical function or quality of life at 12 months between people who kept their bladders and those who had a cystectomy. And actually, most of the patient-reported outcomes favored cystectomy. So patients who had cystectomy at a year had better physical functioning, better cognitive functioning, better mental health. They had lower financial toxicity, and they had fewer recurrences because they don't have a bladder anymore. In the patients who kept their bladders, really the only domains where they were better or things were better were bowel health and sexual health. They did have improved progression-free survival, but that does speak a little bit to some of the selection bias in who ultimately underwent cystectomy up front versus the bladder-sparing therapies. But there were no differences in overall survival or cancer-specific survival. And I think this is one of the first studies where this is one of the lowest mortality rates that we saw with cystectomy as well. The mortality rate from cystectomy at over 90 days was 2%, which is lower than what most other series have reported out, showing that really we can safely do this for patients, and it should be discussed early with a lot of these patients.
Great, thank you. Now we're going to move to ongoing trials or trials that have completed and their data is with the FDA with Dr. Merrill.
All right. So I get the great job of talking about all these novel therapies that are coming to fruition, in addition to the plethora that we already have FDA approved. So we'll first talk about cretostimogene. This is an oncolytic adenovirus, specifically replicating inside tumor cells that have retinoblastoma alterations. And so ultimately, it allows selective replication and then tumor cell lysis in, again, only tumor cells and not in regular bladder cells. The virus is also engineered to express granulocyte macrophage colony stimulating factor. And so this provides a secondary effect of this agent, which enhances the immune system detection and then attack of the cancer cells. So this combined effect of viral lysis, of tumor cells, plus the GM-CSF mediated immune activation is purported to allow for longer lasting results and a durable immune response. So cretostimogene has been assessed in really the spectrum of high-risk disease, of course, initially in BCG unresponsive disease, but is also being looked at in BCG naive, BCG exposed, and also as adjuvant therapy in intermediate risk disease, so following TURBT. Interestingly, they've also moved the pendulum forward and looking at it in combination with pembrolizumab in BCG unresponsive disease, as well as with gemcitabine in BCG exposed and unresponsive disease. Cretostimogene in the BCG unresponsive population has shown a 75.5% complete response rate at any time and a 42% complete response rate at 24 months. This drug is FDA fast-tracked, and we expect some regulatory decisions in late 2026. On to the next one, which is, I will tell you, a mouthful, belzutifan, serolican, so we'll just say Belsar, and that's how it's more commonly known. This is a very unique drug. It's an injection. So cretostimogene, it was still an intravesical, again, liquid, formulation. This is an injection into the tumor itself. It is a virus-like particle conjugated to a light-activated dye, which selectively targets and binds to proteoglycans, which is highly expressed on membranes of many malignant cells. And so after injection the first day into the tumor, again, left in situ in the bladder, so you're not doing an upfront TURBT here. The next day, then the drug has ultimately bound to the tumor cells, and you light activate it with near-infrared laser. This light activation triggers a localized acute cytotoxic effect, destroying the tumor cells while preserving the surrounding healthy cells. Now, when doing this changes the tumor microenvironment to be a pro-inflammatory state, which is purported to promote that durable long-term immunity and reducing recurrences. Bel-sar is being looked at as a phase 1b and 2 clinical trial in both intermediate and high-risk disease as this window of opportunity trial in which you inject, you pre-treat, and see what happens, and then do the TURBT down the line if needed. So interim results here have shown tumor shrinkage, rapid immune activation, a favorable safety profile, and in a subset of low-grade tumors with light activation, Bel-sar has shown complete response. So Bel-sar has also been granted FDA Fast Track designation. Next on to EG70, or known as detalimogene voraplasmid. This is a non-viral, so unique in that manner, gene therapy, which delivers a genetic payload that encodes interleukin 12, as well as retinoic acid-inducible gene agonists. And so this allows stimulation of both the innate and adaptive immune systems. And ultimately, this dual approach really shifts, again, that tumor microenvironment to be a pro-inflammatory state, promoting tumor clearance and long-term memory against recurrence. The novelness here is that it is non-viral, and so theory is that it allows for maximized anti-tumor effects while minimizing toxicity. Detalimogene is being explored against the entirety of the high-risk spectrum, of course, initially in BCG-unresponsive disease, but also being looked at in naive and exposed and papillary-only disease. Its results, interim results, have shown a complete response at any time, over 54% in a heavily treated population. And it has been granted by the FDA both regenerative medicine advanced therapy and fast track status. And potentially a BLA will be submitted in late 2026. Another one here that is just new to the platform is NDV-01 by Ramalda Therapeutics. This is a sustained release intravesical chemotherapy with gemcitabine and docetaxel, allowing the slow release of both these chemotherapies over 10 days. So this allows that prolonged tumor exposure to these chemotherapeutics while minimizing, again, toxicity. NDV-01 forms a soft, spherical, biodegradable matrix within the bladder, and this matrix actually sequesters the gemcitabine and docetaxel and then gradually releases the two chemotherapy agents as the matrix slowly dissolves over 10 days. NDV-01 is being evaluated, of course, in the BCG unresponsive setting, first and foremost, in CIS plus and minus papillary, and also in papillary alone, and then also adjuvantly in our intermediate risk disease following TURBT. Interim results in the BCG unresponsive population have shown a whopping 94% complete response anytime and an 80% complete response at 12 months. One that we didn't talk about before we go forward is actually from Protera Therapeutics, or is TARA-002. I apologize, we don't have a slide on this, and I don't have great notes either, so I apologize. So I'm going to be looking over to my phone. But ultimately, it is derived from a cell bank of inactivated Streptococcus pyogenes. And what this does is, again, it stimulates the local immune response, both innate and adaptive, and also allows for direct tumor cell kill through an immunogenic cell death. And this drug has been explored in the BCG unresponsive setting, as well as in earlier states of the high-risk disease, and it as well has been deemed FDA fast track status.
I think we should all give her a round of applause for her getting all that out. Good job. Thank you, Suzanne. All right, so next we're going to move to the systemic therapies for high-risk non-muscle invasive bladder cancer with Dr. Kessler.
Thanks so much. So as we think about these systemic therapies, many of them are going to hinge on these checkpoint inhibitors. So these are drugs that target either PD-1, so programmed death 1, or the programmed death ligand, and the interaction that occurs between those to suppress immune response. So as we use these agents that target that, that should then reverse that immune suppression, stimulate T-cell activation, and basically an immune response to affect the tumor. Pembrolizumab is a PD-1 inhibitor. This is a drug that was approved many years ago based off of the KEYNOTE-057 study. And if we recall that study, it was a single-arm study with 2 cohorts. The cohort A group is the group that led to this approval. So those were patients who were enrolled with CIS with or without papillary disease. There was about 96 patients in that cohort. And based off of that endpoint of complete response at 3 months, this drug was approved. So 41% of the patients had a complete response at 3 months. Of those responders, an additional 46% continued to respond at 12 months. And the duration of response, or the median duration of response in those responders, was about 18 months. I think as we talk through these systemic therapies, something that oftentimes comes up is the tolerability or the treatment-related adverse events. So if we consider the KEYNOTE-057, the treatment-related adverse events were graded as 3 or 4 in about 14% of the patients. There were 73% treatment-related adverse events reported overall. And as we think through many of those high-grade events, those are going to be immune-mediated or events that result in some need for additional immunosuppression. This is not an FDA-approved combination, but certainly a trial that has already received much discussion at this meeting. So the Potomac trial evaluated durvalumab plus BCG. Differently than the pembrolizumab study, this cohort of patients were enrolled with BCG naive. So pembrolizumab is approved in the BCG refractory setting. In the pembrolizumab study, that drug was given for up to 24 months. In the Potomac study, the checkpoint inhibitor here, durvalumab, is given for up to 12 months. And in this study, there were 3 arms, so patients were randomized 1:1:1 to receive either durvalumab with BCG induction, durvalumab with BCG induction and maintenance, or the BCG induction and maintenance alone. And so as many of you may be familiar with, this is a very active combination with a reduced event-free or an improved event-free survival hazard ratio of 0.68, so a 32% reduction in events. And many of these patients that benefited most were probably those that had the high-grade papillary subtype. So again, a promising combination that met its primary endpoint. Similarly, the treatment-related adverse event rate was high-grade, about 20% versus 4% in the BCG alone group. And many of those patients with those high-grade AEs required systemic steroids, so 16%. 27% of patients discontinued therapy in the Durva BCG arm compared to about 17% in the BCG only arm. So again, this balance of clear activity with some of the treatment-related adverse events.
Great. So we just heard about 20 different agents that we can use for non-muscle invasive bladder cancer. I think, the FDA did a great job by getting a lot of these trials going, but I think it leaves the clinicians in a little bit of a fog because we don't know what drugs do what, like head-to-head. All of these are single-arm trials. So I think what we wanted to really focus on now, we put together some, ways that we kind of sequence things and ways that we think about things to kind of give you some tips and tricks how to use this actually in the clinic. Most of the time, what we're choosing is driven by patients, toxicity, and what was mentioned here too, logistics. Like some of these do have logistical challenges that might work better in some offices than others. There's no clear algorithm in treatment sequencing. I think the vast majority of us will try 2 or 3 agents and then eventually call it and move to cystectomy. These patients tend to have like pretty resistant disease, so you have to be willing to abandon and move on so that you're not risking progression and upstaging. There's really, BCG reinduction. So all these trials for the BCG unresponsive, as everybody mentioned here, they had to have the 6+3 or 2 inductions. And then I think the real question is, if we're trialing these up front, is BCG reinduction going to be something of the past? All right, and then systemic versus intravesical. Obviously, systemic has a much broader immune activation. Intravesical with much lower toxicity. Patient selection, I think, to systemic therapy is critical. The response rates to systemic therapy are lower than most of the intravesical options that we talked about here. I like to use 2 years. That's just kind of my personal bias when I talk to patients, like where are you going to be at in 2 years? What's the chance you're going to be cancer-free? And so, those toxicities add up over that time period. All right, clinical trials, I think they're still very important. I think trials continue to guide our future standards, and there are still a bunch of trials that are actively enrolling, so some patients might be right for those trials rather than one of the therapies that we talked about here. I don't think that any of the therapies we talked about here are gold standard and are going to cure all bladder cancers. So there are still patients that are going to qualify for clinical trials, and I think we will continue to see clinical trials in this space. Hopefully we can see some that run head-to-head, but probably not as many as we'd like. All right, so this is just going to be discussion time, and if you guys have any questions, please come up to the mic and ask us. I just want to pause right now. Does anybody have any burning questions before we get into the cases? You guys are so good. No questions. Well done. All right. So 65-year-old guy, T1 high grade with carcinoma in situ, re-resection, just carcinoma in situ. Dr. Merrill, what is your first line therapy here? Do you do BCG, Pembro, TAR-200, cystectomy?
Yeah, so we're thinking about this as, again, new diagnosis.
Actually, you know what?
Oh, okay.
Yep. We're going to do this, and then sorry.
Love it. No, yes.
Yep. Okay, so everybody log in. If you hadn't logged in earlier, the QR code is right on the right-hand side there. So what is everybody doing first-line therapy here for this patient? And then we'll kind of go through our rationale of what we like to do. All right, BCG induction. So I think most of us would agree, as that slide did, that BCG induction is first here. So Dr. Merrill, walk us through your thought process for this.
Yeah. So again, this patient we were trying to outline is a new diagnosis of high risk, and many of us would consider this very high risk, CIS T1. So really important factors that we didn't put in there, but just to highlight, you want to make sure in such a patient that you're doing, again, imaging, a CT urogram, looking outside the bladder, making sure you're not missing any nodal disease, upper tract disease, et cetera, that this is truly a bladder-only disease. You also want to make sure with such very high-risk disease that you're taking the patient back for repeat TURBT. That is in our AUA guidelines, making sure this patient doesn't have underlying muscle invasive disease, and you have that patient on the right track of thinking about, again, a non-muscle invasive bladder cancer treatment. So BCG for our high-risk and very high-risk patients right now, in terms of what is FDA approved, BCG is, again, top line. I think what's going to be interesting coming down the pipeline is with Bridge, soon to read out, that's looking at, again, BCG naive, high risk, BCG versus Gem-Doce. Is that going to swing the pendulum to where, we could be considering Gem-Doce in such patients? And then, as you well know, with Potomac and durvalumab seeking, again, regulatory status very soon, could we think about in a patient that is very motivated, good performance status, no rheumatologic issues, could you add durvalumab to BCG, again, in the upfront setting to target such very high-risk disease? But right now, again, what's FDA approved and recommended by our AUA is BCG induction.
A quick question. How many people who are here have issues getting BCG in a timely fashion? No. Okay. So I would say that's the other piece of this. I was in Louisiana before I went to UNC. We had no issues with BCG. We got 110 doses a month. Everybody got full dose BCG, like within 2 weeks of their TUR. And when I got to North Carolina, that was not the case. There was a huge access-related issue. And I think that while we don't have the results from Bridge, we have patients on that trial, and I think people are using it. And I think that early, timely treatment also really matters. And so weighing that risk between if we can get you BCG in 4 months, or we're going to get you something now, is important. And so what I actually will do for a lot of these patients is I will use the Valor Lab, the VESTA test, which looks at, do they have basically a BCG biomarker, and that predicts their response. And so for people who are less likely to respond to BCG, I actually will use Gem-Doce for them, and it's because of the resource constraints that for me is a way to sort of prioritize the BCG versus Gem-Doce. It's not validated or studied in that setting as a disclaimer, but I think in the real world access to BCG does still remain a problem.
Yeah, and I use Valor Labs too, and definitely have done that in this setting. I think the one to caveat, now again, if you have both agents available, BCG plus Gem-Doce, is that you do have to allow these patients to know if again, you're going towards Gem-Doce for whatever reason, Valor Labs or patient's preference, et cetera, is that if they do, recur after that, in order to, many times, unfortunately, because how our trials are laid out, and again, how all these new novel therapies are in the BCG unresponsive setting, they will still have to undergo BCG, to be able to meet criteria. So this is an unfortunate situation with our trials right now, and how they are labeled. It's not treatment exposed or treatment, again, unresponsive. It is reliant on BCG. So just something to keep in mind that I'm sure we all have the conversation with our patients when we, use Gem-Doce up front.
Absolutely. All right, we're going to roll into, any have questions about that, comments? All right, we're going to roll into our next case. So this is a 72-year-old female persistent CIS after adequate BCG. What's the next best treatment option? Nadofaragene, repeat BCG, surveillance, TURBT only. All right, we're losing participation, guys. This is the fun part. Let's get some more votes in. All right, nadofaragene, yeah. Dr. Westerman, walk us through thought process for nadofaragene for this lady.
So I think I started to realize the toxicity sometimes that we cause for these patients, especially in their 90s, it's real. And I think that it's sometimes just the repeated trips to come to the office and get in the car and drive. So for a patient like this who is older, the Q3-month dosing I think is probably really beneficial just from reducing treatment burden time coming to the office and things like that.
Let me ask you guys a question. So for nadofaragene, how many doses do you give before you say that, and you're still seeing like CIS type changes in their bladder? How many doses do you give before you say they're not responding?
I mean, I would give at least 2.
Correct, too, yeah. So, right, maybe to comment, the original trial that allowed the FDA approval of this did not allow what we call reinduction. So it was 1 dose, 3 months, recheck. If they recurred, then they were out. In the real world setting, now there is, data that people have been reinducing, which we're all very, used to with immune, again, stimulation drugs, that it seems to have an effect, especially in our CIS patients. So a lot of us are moving forward, even if we are seeing something little. I think we all put it in context with how much volume of disease we see. Certainly if we see a big papillary tumor like T1, we're not going to reinduce, that patient. That patient is showing us a different, disease biology. But a little CIS, a little TA high grade, no problem. Give them another dose.
Yeah. The answer to this question was nadofaragene, but I also think that there may actually be a place for surveillance in someone that's 92. Yeah. I don't think that they absolutely have to be treated. Most of the time CIS is going to become muscle invasive over, about 50% at 2 years. So those are kind of the numbers I always use. And so is the life expectancy going to be 110 to make this worth it? I don't know. Obviously, it's a nuanced thing, but I think those are discussions that have to happen as people are aging. What is a thoughtful plan?
Yeah, very good point.
Median life expectancy at that age is about 4 years,
Yeah.
3 to 4 years.
Yeah, but I think we do, because I've been having more of these as well, we really, like with BCG and some, I think we cause real harm with some, especially in some of these older male patients.
They mentioned this yesterday at the plenary, some of these repeated treatments with the lower urinary tract symptoms, all that keeps them up at night, increased dementia, increased, Alzheimer's diagnoses. So we do need to be a little bit thoughtful about, not every single patient benefits from these treatments. All right, next one, 68-year-old male BCG unresponsive CIS plus TA high grade. This is a preferred approach of everyone here. All right, great. Let's see what we got. Hey, look at that. All right. Dr. Merrill, are you using Anktiva?
Yes, I am. We thankfully have not had too much of an issue with BCG, but as Dr. Westerman laid out, that this has unfortunately initially crippled the use of Anktiva, thankfully with their recombinant program, et cetera, and likely in the foreseeable future this won't be an issue. But I will tell you the personal kind of patient issues I've had with this agent, as again, we're talking BCG unresponsive CIS. Now we have a lot of options in this space, is that when I'm talking to patients and they hear that an option is in combination with BCG, sometimes it's hard for them to understand that that's going to work. And so that can be a challenge, but it does have a really good efficacy and durability, this drug. I think the other things, to mention here, and when we're talking about what treatment to start with, is we're not only looking at, patient factors, right, their current bladder symptoms. This drug is given very similar to how BCG is, 6 weeks. And then you can even re-induce them, and then similar maintenance time period. But we're also looking at their prior treatments. So, for example, did they just come off BCG, an immune, again, stimulator? Is this going to work best? You could use the Valor lab test to help differentiate, is another immune agent going to be preferable, or chemotherapeutic? Or did they just come off, again, gemdosi, upon which switching to a different mechanism of action, such as this, might be valuable? So a lot of us take into context what their prior treatments are, kind of when that recurrence time period was it really quick, was it a long durable response, et cetera, all comes into play when we're deciding of that next best agent.
Yeah, I'll tell you what I'm most excited about. I'm most excited to see this in the upfront trial.
Totally, in BCG naive. Yeah.
In BCG naive. I am so excited to see if this pans out in that setting.
Right, and really show.
Because why wouldn't it?
Yes.
So, good, excellent. All right, let's roll into our next one. So we have 75-year-old male, BCG unresponsive, refuses surgery, best systemic option. Go pembrolizumab, BCG reinduction, TURBT alone, or nothing. All right, so 100% pembrolizumab. So I have the great pleasure of working with Dr. Kessler all the time. So Dr. Kessler, talk us through who is your ideal patient that you really would want to give pembrolizumab to. I think we use it in our practice a lot more sparingly than people in this room reported. So just kind of walk us through your thought process on some of these patients.
Yeah, I think that pembrolizumab, when it was first approved, was approved in a space that looks very different than the discussion today. I don't think we could have sat here for 90 minutes and talked about, options for non-muscle invasive bladder cancer. And it really is for those patients who would have met the criteria for the study, which includes patients who are not considering cystectomy as part of their treatment plan. Patients needed to have an ECOG of 0 to 2. The median age was 73, which is maybe a smidge older than some of these other studies that we're seeing. And so it's I'd say, a unique patient population that may not want to come back into the office all the time, recover from surgeries, et cetera. That being said, as we have these discussions with patients, checkpoint inhibitors are great when they're great, and they're really tough when we have these unexpected toxicities that arise. And so we do make sure, as we counsel patients for this therapy, that at any moment there could be an immune-mediated side effect that, while not always life-threatening, could be life-changing, and just kind of counsel them through what that might look like to have new type 1 diabetes, or the need for chronic systemic steroids, or a hospital stay, et cetera.
All right. So a little bit more unhealthy patient, 70-year-old female, has heart failure, has a 4-liter oxygen baseline requirement, has CIS, TA, high-grade, papillary only, recurrence after BCG. What is the best therapy? TAR-200. Surveillance is also very reasonable. So Dr. Westerman, walk us through TAR-200 patient selection for you. Who's getting it? What are some things that you think about patients that might not be the greatest candidates for it?
Yeah, so the biggest thing that, keep in mind, we've only had it for a couple of months, is how is their bladder doing?
Yeah.
Because I think that if you think about having a device sitting in your bladder for weeks at a time, that's slowly releasing gemcitabine, I think that can cause a lot of tolerability issues. And so that's the biggest thing, is how well is this person going to tolerate it? Because especially in our practice, it's not that easy to get somebody in for a cysto if they want this taken out sooner. And so it then actually generates a lot of phone calls and burden for the nursing.
Yeah. How about patients that maybe don't have tremendous lower urinary tract symptoms but do have recurrent infections? Do you think of it as a nidus for infection? Do you worry about that at all?
If they're true, I think if they are having true recurrent infections, yes. If it's somebody is dipping their urine before they get treatment, right. And no, that I do not. But yes, especially again, also in these older men who do not empty their bladders well.
Yeah.
It's tough, as right now, this has the highest CR anytime.
Yeah.
So that's why it's attractive. But
I also, just to be fair, it's only 12-month data that's been published. And so that's what's in the package insert. So as you see these other history of trials, the durability is not usually there.
Right.
So I really think it's
50%
very important
months.
that we see and that we figure out how to compare these to patients really on a level playing field.
Yeah, very true. Yeah, and we do have to be careful, right, of we hear these numbers in isolation, but then of course our minds are always internally comparing them to other agents, and we really shouldn't do that. But I think what the thing here is this kind of induction phase, I use that word hesitantly, but the treatment intense phase, the beginning, is 6 months. Yeah. These patients are coming in and out receiving this. So they really have a device in for 6 months. And I think what a lot of us are realizing, so again, like I said, it's attractive because of, again, the efficacy that's laid out there right now. But in terms of the side effect profile, a lot of us in the real world are seeing, as Dr. Westerman alluded to, that it's less well tolerated than it was in the clinical trials. And we see that a lot with clinical trials. There's a lot of vigilance that goes into it. There's a lot of patient support. And then when we put some of these therapies out into the real world, there is less support for our patients. And so it can be challenging.
Yeah, I'm wondering in the room, has anyone taught their PAs to remove TAR? Yeah. Well, helpful.
Yes, very helpful. Especially because, again,
Every 3 weeks.
These drugs, just as we talked about notapindican or Anktiva, this is being looked at in the earlier high-risk settings, so the BCG naive. And so certainly if this drug gets approved in the BCG naive, that is going to upsurge the number of, cystos in terms of the retrieval.
Yeah.
So something for practices to think about.
All right, 60-year-old male, TA high grade, multiple recurrences after BCG. What is a reasonable salvage regimen here? Gemdosi, TERP, antibiotics, none. I tried to make this one really obvious, so you guys can just pop that in there real quick. So hilarious. So I want to talk about gemdosi a little bit. So while this is not something that's ever going to be like a quote unquote FDA approved regimen, I think it's a very effective regimen. And I think that's why we started studying it in the, patients that are naive to any treatment, because we do see a great response and some durability on it too. I mean, of all the things we talked about, it's about 40% at 2 years for the BCG unresponsive group. So up front, it should actually theoretically be more, and hopefully will be on par or better than BCG. So I think it's a really effective combination. I think there are some definite logistical challenges to those patients being in your office. For a long time, when I first started using it, we would keep them there for the gem and the dosi. We send people home with gem all the time in their bladders, so I went to pharmacy and I was like, do we have any reason to not send people home with docetaxel? And they were like, no, not at all. And so then we started sending them home with the docetaxel in their bladders to cut some of that time. I mean, we still have patients that have severe symptoms that we leave the catheter in and like let them spasm and then it goes back in and stuff like that. But I do think there are some tricks that you can use to kind of integrate this into practice.
I think the other downside from a practice standpoint too is depending on the financials of how you run your practice and whether it's private practice versus an academic setting. Just the reimbursement on this is not there, and so for a lot of these newer drugs, there are margins in the buy and bill, and I think for with declining reimbursements on other things, sometimes, that also factors in like where people will come from hours away to get this because they can't get it anywhere else.
Yeah, I mean, and if you have a PA or NP billing it, it's like 0.9 RVUs for them. So they're much more effective seeing a new patient or something like that, even though this is something that we need to be part of our practice. So that's a great point.
Another important point about these cytotoxic agents compared to our immune agents is that you don't want to re-induce cytotoxic agents. Our thought here is that, again, the cytotoxic agent with a tumor is effective with, contact. It's not generating this durable immune, again, response. So, blasting them again with more cytotoxic agent after you've already seen them recur is not going to do any good. So I think that's just a really important point because, again, with our immune stimulating agents, we really do think that there is a benefit to re-inducing. So you don't want to do that with our cytotoxic agents, whether single agent gem or people if you're using mitomycin or, again, this couplet here. I think the one thing with the new novel drugs coming out, which I'm super excited about, is, again, this formulation in this NDV01. And again, we really do think kind of this technological advancement of trying to figure out, just like with, TAR-200 or Inlexo, this prolonged exposure of these cytotoxic agents will be helpful in terms of efficacy, and actually it allows for, again, a lower blast of that cytotoxic agent to the urothelium, therefore reducing the side effects too. So there's a dual advantage.
Yeah, and I think as hopefully some of these move earlier into the treatment paradigm, we'll see less tolerability issues because the urothelium has not already been beat up so badly.
Not bad bladders yet. All right, case 7, 66-year-old fit, BCG unresponsive CIS. What's the best approach? Trial, do nothing, repeat TURBT only, or radiation? There we go. Clinical trial. Yes, I agree. I think that clinical trials, even though we have an evolving landscape, we still don't have clarity on where to go and what to do. So I agree with this. What do you guys think?
Yeah, I agree. I mean, I think obviously there is a huge need for head-to-head trials, comparator trials. One trial which we didn't talk about here, but that I actually enroll a lot to is NRG14, which is a cooperative group study looking at using either chemorads or IO-rads in very high-risk T1. So these are patients who should have a cystectomy. These aren't really patients we're talking about here. These are the variant or subtype histology patients, T1s after induction early. And so, I think that is another, a nice study. It's only something that should be done on a clinical trial because there's very limited data out there for it. But that is actually the one that I'm currently utilizing a lot of.
Yeah, I think that's a really important point is you have to wait for the clinical trial to be complete. Yes. And sometimes you have to wait to see, like in real life, what do those things look like before you really adopt and change your practice. So I think that's a really good example of something that you usually don't do off clinical trial, but clinical trials are really useful for certain patient populations.
Yeah, and one thing I think we've heard today is how these trials are designed really impacts how we can counsel our patients and talk with them. And so we've really talked about what are the endpoints, when are those endpoints obtained, and I think there's a lot more thought going into that in this space because there is so much activity, which is nice to see.
All right, so now I'm going to poke all of my panelists. So we have a cysto trial that says cystectomy is better in a lot of ways. We have a whole bunch of stuff that kind of works, but we have a cure to this disease called cystectomy. So tell me, when is the right time?
So I start talking about cystectomy as early as possible, even when it's just to say, this is not indicated for you right now, but this is something that we may treat bladder cancer with.
When you say that, do you give them like there's 50-50 chance you're going to have recurrent? Like, what do you say?
I actually will bring it up before their TUR. Okay. And I will say, yep, there's something in your bladder. We're going to find out what it is. And our big picture path, it could be anything from we look again with a camera all the way through, maybe some medicine in the bladder or systemic like chemotherapies or medicines in an IV and taking out your bladder, just so that they sort of know that is one of the things that we use. And then really what, so by the time we're on the second, the second therapy, really, especially if people are having side effects or their bladders are not functional, we'll start to push a little bit more for it. And I also think for a lot of these patients, it's the time to that first, the time to first recurrence. Do they have a high-grade recurrence at 3 months? That's different than you've gotten some BCG, you got, your 3 and 6 month maintenance, and you have a TA recurrence at a year.
Yeah, I want to emphasize one thing about the recurrences. So I generally, for low-grade recurrences, do not switch therapy. I continue on unless I'm giving it for low-grade. But if I have one of these high-risk patients that has a low-grade recurrence and they're on BCG, I would just continue BCG. But yeah, Dr. Merrill, when do you cystectomize?
I think from you can talk about it in the upfront setting for your non-muscle invasive bladder cancer patients. In that situation, I am really thinking of more your high volume T1, again, these other very high risk factors, throwing in CIS, LVI, variant histology. But it is more the T1 patients that are high volume that I get very, concerned about. And then if we've all been in this situation, it can be such high volume many times, you can't get it all in one TURBT, so there's residual disease left. And so I tell the patient, listen, do you want to undergo another TURBT? And, see if we're still at T1, maybe we'll be upstage then. Or are we moving towards, cystectomy at that standpoint? So that's more the patient that I'm having that conversation with of cystectomy up front. But I think in this setting here where we're in today's world, this, BCG unresponsive setting is to, how many of these bladder sparing therapies are we willing to cycle through? before pulling the trigger, I think it's kind of up for debate. There's some of us that feel comfortable doing a couple lines of therapy and then saying, yeah, this is getting too risky. And I think what's important for all of us here to understand that with every recurrence, that happens in these novel therapies that's of significance, like Dr. Kukreja said, so not the low-grade recurrence, certainly the CIS recurrence for sure, their risk of progression of disease increases each time. I don't know if people have any percentages, but it can be, into like 14% of increased risk each time. So, it's really something that you have to make sure that you're, one, evaluating these patients with a CTU, making sure you're capturing, this potential transition, and then being able to salvage them appropriately with that cystectomy. And just making sure there's full clarity of what's going on in their bodies before saying, yeah, we could try another bladder-sparing therapy, because the reality is these patients know that these drugs are out there nowadays. They don't want to lose their bladder necessarily if their bladder's not causing too much hostility to them. And I think we need to be the wiser of, the two in the room to make sure we're not missing a situation where we can provide that cure for them with cystectomy.
Yeah. And the one I was just going to say on the T1s, I actually almost never do upfront cystectomies, often because I will take my T1, the T1s that come in back and re-resect, and they're almost always understaged. And now that we have EV Pembro, and these patients should get it, I will try to resect everything and really make sure that they don't lose their opportunity to get systemic therapy up front before a cystectomy if they're T2.
Yeah, no, it's very true.
All right, Dr. Kessler, when are you telling them to go away, go to the other side of the office?
Well, usually if they're coming to see me, that's been part of the discussion all along, right? So I think similarly, I include it, I don't totally know, but oftentimes I'm working quite closely with the urologic oncology surgeons to understand how functional is this person's bladder, how many lines have you already tried, what did their last TUR look like to you, so that we can really understand. But I keep it as a part of the conversation along the way. And even for people who have very clearly said that's not something I want to pursue, I think that there is something to be said for being both an informed but also experienced patient. And the longer that they go through this, their perception on some of their approach to care may kind of shift over time. So I just keep it as a continued part of the discussion while also being informed by the surgeons that I work with.
Yeah, I think we talked about it a lot today, but I think something we don't really know how to disclose to patients is what happens to their bladder over time with all these therapies. And so I think patients really do often end up with bladders that do not store properly. They get infected a lot because the urothelium is not healthy. It doesn't clear the bacteria like it should. So I think, very recently, Dr. Kessler and I had a patient that was like, well, you didn't tell me this is what my bladder was going to be like. And I was kind of like, well, yeah, and so I think that's something we don't necessarily disclose, but also we don't know how to describe it and who's going to get it. We know that some of these become defunctionalized and some are totally fine. There's not really a great way to predict that either. So I just have a quick little algorithm here. So basically just kind of how, outlining how to think about things. So BCG naive, high risk, the standard of care would be full dose BCG induction and maintenance. We talked about in the setting of BCG shortage, a lot of times we're half dosing or third dosing. I think there's great guidelines on the AUA website on what to do with BCG shortage, and upfront clinical trials in the naive setting I think are really great. BCG unresponsive, so these are generally patients that get 6+3 or 2 inductions 6+6. That have CIS and papillary, plus minus papillary. We use nadofaragene, the N803 with BCG, TAR 200, or throw in some gemdosi. And then consideration for pembrolizumab if they're a systemic candidate. What are the high-risk features, the ones that we really get very concerned about that really need upfront cystectomy? T1 high grades that have LVI or behave like muscle-invasive disease, they should be treated like muscle-invasive disease. T1 sarcomatoid, plasmacytoid, all those early cystectomy patients. Some of the variants that I do not take for early cystectomy, squamous differentiation, glandular differentiation, those ones don't really hit the same way as like a sarcomatoid or plasmacytoid or something like that. I think throughout all stages, prioritizing clinical trials, we would not be sitting here having this discussion if clinical trials were not prioritized and getting patients into those clinical trials. And then, really, we don't have any fixed sequencing, but it is probably cancer dangerous to let patients continue to just go on and use every one of these agents and still have carcinoma in situ in their bladder. So at some point, we are going to need to figure out the sequence and figure out when is the time to pull the trigger. But I do think talking about cystectomy from the very beginning really, and I would say not talking about it in a negative light, right? Everybody, a lot of people are like, I don't want to have a surgery, but understanding what not having a surgery means, I think, is also really important. All right, so some key takeaways. This is a very rapidly evolving landscape. There's multiple FDA-approved options now available, no defined sequencing. Shared decision-making is really essential here, and clinical trials remain critical. So we're going to roll into our post-test here. I just want to take this opportunity before you guys start taking the post-test to thank our panel. Let's give them a round of applause. They did an awesome job. And they all came here. Some flew here just to do this with us. So thank you so much for being here, guys. Really appreciate it. Well, I want to thank everybody for coming and for your audience participation. I hope this is a really educational session for you guys. I hope you guys have a great day.